All right, I didn't want to jump in too early. Hi, I'm Paula. Thank you. I love that your opening there. That was great about hygiene in the profession. Tonight we are going to talk about gingivitis and periotherapy. Super exciting. Yay. I am going to get a little deep on some clinical stuff, but we're going to get into some other objectives here that I'll go over. I'll do my own introduction, my own little bio. I've been a registered dental hygienist in the state of, well, Indiana and Arizona. I'm originally from Indiana. I've been in Arizona for just a little over 25 years. So I spent about 1 year doing hygiene. I did 7 years of dental assisting in Indiana, 1 year of hygiene, and then I moved to Arizona basically. So still clinical today, just not as often. I now own Next Level Consultants. So I hope I get to do my passion and help other practices grow and get to talk about Perio and bring best practices to offices. So whenever I'm coaching out there, I always just say, listen, I know I'm not smarter than you. We all graduated from a probably an amazing school, but what I do get to do is I get to coach hundreds of practices a year, or I should say hundreds of team members a year, and I get to bring best practices to each and every one of my offices. Um, I have owned a couple dental practices, so not only have I been a dental assistant, but a hygienist, but I played a dentist on TV. Um, I did have associates in my practice, and sometimes I felt like I did things that a dentist should be doing, but just kidding. I never went out of my scope of practice. I've also been a hygiene speaker for Invisalign for the past 2 years, and I spoke for BioLays. That's a whole nother story, but they got swallowed up. But I was on their faculty team for about 7 years, so have a huge passion for laser dentistry and dentistry as a whole. So enough about me. Oh, I should just say, these are my those are my two daughters, but they've moved out. And so these are my two fur babies. Those are my kids now. And then I do have a grandbaby on the way. My middle child is uh, going to almost be 26 and now expecting. So super exciting, kind of. I don't really want to be a grandma yet, but I am going to be one. Just trying to advance my slides here. Okay. All right, objectives, you guys can all read, but basically identifying clinical signs of both gingivitis and periodontitis, differentiating between the codes, talking about applying verbiage to communicate all of those things, confidently presenting treatment plans and financial conversations, tracking. I think metrics are huge, and incorporating a patient-centered communication strategy. So we'll get through this tonight. I'm going to try and stay on time. Just minimize this. Okay. So diagnosing right the first time. These are difficult conversations with hygienists many of times because I never, I respect we all are licensed professionals and I do respect that. However, being in the field for 28 years, I've experienced it. I've been around it enough to know that we sometimes get comfortable. We get patients that are grumpy. We are always on a time constraint. So a lot of things that go into diagnosing, and sometimes guilty is charged. There's been times where I've either jumped in, had, feet first, or just wasn't there all the way, whether my patient was grouchy or my patient was 20 minutes late, where I got into doing a prophy, and lo and behold, it was something else. So, this is a chance for us to build value. You probably heard this 100 times, but we get to spend more time with our patients than most, if not every healthcare provider out there. Not only do we usually get a full hour with them, but we also get to see them twice a year. And if you think about it, there's really no other, medical profession out there that does that. So we have a chance to build a lot of value. So when we code correctly, we protect the practice, we build trust with the patients, and this whole conversation is not about upcoding. We're going to be talking about, again, those difficult conversations, but it's just really being about about being accurate and confident in our diagnosis. So diagnostic consistency also creates business data that we can track to see how many patients need therapy, how many accept treatment, and whether we truly are treating what we see. So we're going to talk a lot about diagnosis and diagnosing right. The value of the diagnostic integrity in the hygiene department really is what sets the tone for everything. The patients, it creates clinical excellence. It sets the patient's understanding of the condition, their willingness to accept care, and the overall success of the practice. So when we diagnose correctly from the very start, means we get to catch disease at its earliest stages. How great is that? Especially with periodontal conditions that can progress silently and cause underlying issues in patients in other ways, even their overall health. So this means the patient receives the right treatment before it gets worse, before it gets more costly, before it's irreversible, and above all, before it causes other damage to their health besides just the mouth itself. It also builds trust through clear communication. So we want patient trust. So when we accurately assess and diagnose, whether it's inflammation, disease, or health, we reinforce that we are clinical professionals. So if we misdiagnose and somebody else tells them, or they come back later and we have to have those difficult conversations, or they've been somewhere else and our diagnosis is different, some of this creates distrust. And sometimes we don't ever really even know this. And most of all, we don't want to be just cleaners. We're assessing, we take a lot of assessments, we take a lot of measurements and metrics, and we want to know that we are looking at all of this when we make that diagnosis. This all builds patient trust. They see and hear what we're using. So when we do collect that data, then they get to hear all that, and that reinforces what we're doing. The pocket depths, the bleeding, the radiographs that we take, and then really tell them the truth about their oral health. It supports proper coding and reimbursement. So this is always a difficult conversation because the way I look at it is we're not here for insurance companies, but we have to honor what the patient values, and patients really want to utilize those benefits. So because we get, and we'll talk about coding here shortly, because we get a basic 4 codes to use, we really have to pick which one's best. We don't have prophy, difficult prophy. And we'll talk about the 4346 because if you're familiar with that, you might consider that a difficult prophy. And then severe prophy, and then we get 4 codes. And I'm counting a 4341 and a 4342, which is limited and full kind of together, because if we have periodontal disease, it's just a matter of how widespread it is. So we don't get a lot. So we have to play the game of the insurance where we're doing what's best for the patient, but we're also picking the proper coding so that we can help them get that reimbursement. And obviously, so the next person that sees them, or when we see them again, we realize, what procedure we had to do. So the 1110, the 4346, the 4341 is indicated, does help us discuss with the patient and if we don't do it right, we put the practice at risk. So we want to make sure that we are undercoding because we lose trust. We want to make sure we're not undercoding because we lose revenue. We diminish our perceived value, and we may miss opportunity for early intervention, which is basically my goal, is to always catch stuff at its earliest junction, because it's going to save, obviously, the patient's oral health. It's going to save them money. It's going to save them time. It's going to save the aggressiveness of the appointment. So anything I can do to help minimize all of that for a patient, I want to. It drives our departmental ROI and sustainability. If we're not producing, we might get our days cut. We might not be able to afford 2 hygienists. We might not be able to afford technology, going to CEs. And if we're super lucky and we have profit sharing in the practice, we don't get to reap the rewards of that. Or when we want that raise, it's harder to ask for that when the ROI is not there. So when you think of acceptance, scheduling the right intervals, all of this stuff is going to build our schedule, build our revenue in our department. So we really want to be, and again, I'm going to preface it because we did at the beginning, and I'll say it over and over again. I'm about patient care. So tonight, I'm not asking you to diagnose anything that isn't there. What I'm asking you to do is diagnose it at early stages. Don't wait and watch. Don't worry about planting seeds. And most of all, don't worry about their pocketbooks. Really do what is right for the patient. This also minimizes risk of insurance audits and denials. So I kind of talked about that just now, but um, they're starting to accept with AI. So instead of a human being on the other end, AI is going to be the one to decide if it's eligible or not. They're starting to ask for duration of time. So how much time did it take you to do the perio treatment? And they're certainly asking for staging and grading. So if we are not diagnosing properly, not only, um, is it a little bit of insurance fraud? I always hate to say that. But we might get audits and denials. And when we are finally diagnosing, and then we lose trust with the patients, and we have inconsistency from hygiene to hygiene, depending on what your coworker, your collaborator is doing. So, which just brings me to my last point. It enhances collaboration with the rest of the team. So diagnostic integrity isn't just a clinical priority, it's the foundation of trust, outcomes, and long-term success in our hygiene department. I can't see you guys, so I'm just like talking to the air. So if my eyes are all over the place. Okay, so let's define what health looks like first. So the new staging and grading, if you read, you guys today are going to get, basically, we're going to look at two documents that come out of the staging grading, but this is like a 80-page document that certainly will put you to sleep if you ever want to give it a go. So the staging chart and the grading chart that I will show you today is very minimal of the whole thing. So it does start with health. So we can see more clearly when things aren't healthy. It's defining what is health. So bleeding on probing should be less than 10% of sites, or minimal or no bleeding, indicating stable soft tissue response. So when we have bleeding, there's an issue. When we have more than 10%, there's even a bigger issue. And then we'll get into gingivitis and periodontal disease. Healthy gingival appearance. So no clinical signs of inflammation, such as redness or swelling. It's characterized by firm pale pink tissue with no arrhythmia or edema. So we want to make sure that we're looking at nice, healthy tissue. And even that sometimes when we probe, or even worse, when we get in there scaling, is when it decides to rear its ugly head. Obviously, patients report no discomfort or issues, signs of infection, things like that. No evidence of clinical attachment loss or radiographic bone loss, so none of that. And this all suggests stability and supporting structures. And then last but not least, the crustal bone are within 1 to 3 millimeters apical of the CEJ. If this doesn't take you back to school, I don't know what will. And then, so when we start from health, we can show a patient exactly where the deviation begins. So we want to make sure that we're defining health and what that looks like. Now let's talk about gingivitis. So gingivitis is the earliest stage of periodontal disease. Hang on, I'm going to reset my timer here real quick so I can keep track of myself. Gingivitis is the earliest stage of periodontal disease, but the good news is it's reversible. What defines it? Here are the signs. Obviously, we know these. Red swollen gingiva. So this is equal to or greater than 30%. It must be generalized and affecting over 30% of the dentition. I did the math the other day, and I think it's about, oh, I hate to quote myself. I want to say it's like 8.5 teeth and about 58 bleeding points. I'll have to do the math. You guys can do it. I did it off 28 teeth, not wisdom teeth. So So when we get to this, now we're looking at the 4346. We're looking at using the gingivitis therapy code is what I call it. Um, there's no attachment loss still. So people get confused sometimes wanting to use this prior to periotherapy like we have in the past with a 4355, which is a full mount debridement. But this is stating that there is no attachment loss, there is no bone loss. So we want to make sure that if we're calling a spade, if we're diagnosing the right the first time, gingivitis would not be a precursor to periotherapy. This would be a treatment on its own because we're stating that there is absolutely no bone loss. Sometimes, not always, there's going to be tenderness and sensitivity. Patients often report discomfort when brushing or flossing. And again, this, also can just be subject to our findings, the swelling and the tenderness. And then halitosis, again, not always there. It's not required for your diagnosis, but often present in moderate to severe cases. It also can help patients recognize that something is wrong. So if they come in complaining that they have it, again, there could be some other underlying issues, but typically we've got some kind of gingivitis going on. So let's remember that plaque is the trigger and the host is the response. So plaque is triggering this, but everybody's body is going to behave a little bit different when we have gingivitis. The other thing I don't know if you caught is in the health slide, 10% or less is healthy. And then in the gingivitis slide, 30% equal to 30% or greater is gingivitis. So where does that, 11 to 29% fall? That's a great question. And this is where our clinical judgment is going to come in. I always say when I'm coaching, if I have 29 bleeding points and it's apparently gingivitis, I'm going to call it gingivitis. If I have a pretty healthy mouth overall and it's 15%, I'm probably going to lean toward a prophy. But then again, there could be some localized that warrants the gingivitis therapy. You just have to use your best judgment because typically on the gingivitis therapy, you're going to bring them back for that 4 to 6 week reeval. And so even if there is some localized areas, it's got to be generalized in 30% or more, but it's kind of localized to a certain area, equating to that. We're going to want to bring them back anyways. I don't ever like letting a patient loose, not being on my watch if I'm seeing an issue, because in my 28 plus 7 years, I know where patients go with this. It's already difficult enough to keep them on track every 6 months. And if they walk in with something like gingivitis, I want to make sure that I'm setting them up for success and not just letting them loose for another 6 months. Okay, now we're going to go into periodontitis. When does gingivitis become periodontitis? Well, when we have clinical attachment loss, this is a defining feature of periodontitis. It's measured from the CEJ to the baseline of the pocket. The clinical attachment loss confirms the disease has progressed beyond gingivitis. So this is when it's penetrated into the bone and the surrounding structures, and now is starting to put our mouth at risk. Obviously, radiographic bone loss. Periodiagnosis must be supported with radiographs showing horizontal or vertical bone loss patterns. This verifies the structural damage. Not only do we want to see that to treat, but insurances are, if we have a patient with insurance, they're definitely going to require this. Probing depths equal to or greater than 4 millimeters, typically with bleeding on probing. Obviously, we get smokers, keratinized tissue. There could be times when patients don't bleed, but typically you're going to see bleeding with active periodontal disease. Recession, loss of gingival tissue or detachment leads to visible recession or hidden pocket death. Both reflect a breakdown of supporting structures. So here we are with periodontitis. And obviously, not always, but we can see mobility or tooth migration. And this is more the advanced periodontitis, can cause teeth to shift or loosen due to the loss of bone loss, which is obviously an indicator, and you're now in the more severe stages. Okay, so we've defined health, we defined gingivitis, and now we're going to have a shift focus on this periodontitis. You've probably seen this map or something similar to it. It comes from the CDC. What I want to make sure we see in this is that this is a little bit old data. There's not new data. So I kind of think it's worse. I'm going to be honest with you. But this is alarming enough that 47.2, which is nearly half of the American adults of 30 years or older, have some form of periodontitis. 8.5 have severe. And when you increase that age to 65 and older, that bumps up to about 70% of adults. So we can see that this is not a niche problem. It's very widespread. It's a chronic disease. It's also higher in men, smokers. Sometimes education and income come into play. People with chronic issues like diabetes. This is nearly 65 million adults over the age 30. This is huge. So our hygiene diagnosis is not optional, but it's essential. It's essential to catch early. It's essential to treat our patients the right way. So my very first slide, diagnosing right the first time, is really what I want to get across. I coach hygienists every day. I see radiographs every day. I see it constant. And I do sympathize, because I do know we have real life patients in front of us. I do know that we have time constraints. I know there's a lot of things, and that's one of the things that I help with. And you don't need me to help. You can obviously do it on your own, is having those systems in place. If I get a new patient in my chair that has perio, or gingivitis, am I set up for success financially, knowing the financial status, what it pays, how much time I have? Do I go get my front office? Are they prepared? There's so much that goes into this. And I hope when we get into that a little bit further, that, I can help with a little bit of this when you go back tomorrow. It's only Wednesday. I didn't thank you in the beginning too. I know you're coming tonight for study club, CEs, and to better your profession, yourself. But I just wanted to thank you for, I'm honored to be here and be able to speak to you all. So I jumped right into things and didn't thank you all for that. So I thank you for your undivided attention, and hopefully I give you a couple of pearls out of tonight that you can take back and use the end of this week or next week in your practice. Okay. This periodontal beliefs, systemic links. This became even bigger. We always wondered how the head and body got disconnected. And then after COVID, it got reconnected, thank goodness. And I think this is, more awareness now than it's been in a really long time. So that excites me. But periodontal disease is not just a localized oral condition. It's a chronic inflammatory disease that affects the entire body. So this is the gateway. You can't have a healthy body without a healthy mouth. When the gums are inflamed and bleeding, there's harmful bacteria that can enter into the bloodstream and contribute to systemic inflammation. So if you're not familiar with all of this, if it's uncomfortable, I would love to challenge you to get comfortable. There's all kinds of things you can study on the internet. You can get with a coach. You can get with a colleague. You can take more CEs. There are ways to really get comfortable in this, because it should be part of our everyday conversation. Research has shown that strong associations between periodontal disease and several systemic conditions. So it's not just heart disease, it's not just diabetes. Now it's cognitive decline, so memory, things like that. In particular, patients with diabetes are more susceptible to periodontal infections, and those infections can in turn make it harder to control their blood sugar. So it's a two-way relationship. You've got the diabetes affecting the mouth and the mouth affecting the diabetes. So it really can be, detrimental in the patient's recovery from either one. Then you've got pregnant patients with untreated periodontal disease have a higher risk of preterm birth and low birth weight. And honestly, when, back in the day, before I probably started educating other hygienists, let's call it 10 years ago, I knew this, but I didn't think a ton of it. I'm thinking how many babies are low birth weight, and I guess I just didn't put a lot of two and two together. And when I really started studying it, short-term effects, you're talking hypoglycemia, increased risk of infection, jaundice, feeding difficulties, and neurological problems. There's long-term risk that can happen, which is neurodevelopmental delays. If you guys know, I mean, I have several friends that have preemies. Kind of oddly enough, quite a few friends that have preemies, and this developmental delays is a real thing. You're at risk long term for cerebral palsy, chronic health problems, growth and development delays, behavioral and emotional issues. So you've got all that. And then sometimes an adult onset risk after, you're a child with a premature low birth weight. And as an adult, you can develop cardiovascular disease as an adult, type 2 diabetes, and honestly, chronic kidney disease. So there's a lot of things that can come out of just low birth weight, that I just want to bring that to your attention because a lot of people don't take it really seriously unless you know someone that had a preemie or you yourself. It just kind of is like, okay, low birth weight. Maybe it's just me. That's kind of how I thought about it. So this is why accurate diagnosis and early intervention in the hygiene department are critical. It's not just for oral, but for whole body health and wellness. We educate our patients about those links. We elevate the value of what we do because now they see us as, they may not go to the doctor. We're the only person they see. They might go to the doctor once a year, once every 2 years, once every 5 years. So they now start to think of us as an overall health provider and that we see a lot in the mouth. We see early signs, but we're also talking about the understanding of why the treatment matters. So just think about this when you're diagnosing in the future of all the domino effect this can have on a patient, if we diagnose a positive and if we don't, the detrimental things that can have. There's a video that I watched years ago, and it walks like 4 patients through their journey with a periodontal disease, and they didn't even know they had it. And I kind of forget the whole premise now, but one was she couldn't get pregnant. She got her perio. I mean, years of trying, got her perio treated and got pregnant immediately. One with sleep apnea, cardiovascular issues. So it really does, if we're not treating this, we may not even know the effect of our patient. So if I can be that person to make sure, I can't cure someone of cardiovascular disease, but what I can do is make sure their mouth doesn't affect that, doesn't exacerbate that. I've always been told that the body has difficult times fighting off 2 diseases, 2 issues at once. So if they're fighting periodontal disease and cardiovascular or diabetes and periodontal disease, it's much harder. One's going to take over, one's going to win. And so we want to rid them of one of those obstacles. So now they just have one battle to fight. Okay, staging and grading, as you guys watch this pop up, this is what my brain feels like when I first learned staging and grading. So staging and grading, stage 1, 2, 3, and 4, grading A, B, and C. I can't see you guys, or I would take a poll of like how many people are doing this. I find that not a lot. It's kind of shocking. And again, it's not shaming you guys. It's just once you get out of school, if it's not brought into your office or you haven't taken a CE, it wasn't taught, so a lot of people just aren't using it. So I'm trying to spread the word, one hygienist at a time, that staging and grading is here and it's here to stay. So it's a matter of, when you want to give in and learn it. So we now have a universal language, the staging and grading. It's recognized by the ADA and the AAP, and now insurance companies. It creates consistency across providers. So when you think about, I'll say it now. I usually say it later, but it's going to come out of my mouth. When you think about, and I hate to use cancer, hate it, but if someone says, they're stage 3, we know exactly what that means. And it's kind of why we're going to this universal language, is because, mild, moderate, severe can mean a huge range of things. But when you say stage 3, grade B, you pretty much know the severity and the progression. And that's why this has happened. So it's improving diagnostic accuracy is what it's really doing. So it's clearly defining the severity. So that's the stage, and the progression, risk, which is the grade. It's going to align hygiene teams, so multiple hygienists in an office and across our profession. So it helps hygienists calibrate and speak the same clinical language as do the medical field, all of them, nurses, doctors, everything. It's going to support consistent patient care. So it's going to ensure that all patients are diagnosed using the same criteria. And we'll describe that here in a minute if you're not familiar, or you're familiar and kind of forget. It's going to enhance patient understanding. So it's going to be easier to explain the disease with the structure. So it's very definitive, stage 2, grade B. It's going to back up insurance claims. So we're going to have stronger narratives. We're going to have justification for those codes so that patients don't feel like they have benefits and then unfortunately it gets denied. The more stuff we send out, the better off we're going to be. I always feel like the minute insurance is missing information and they have to question something, we're now in a fighting battle. I also have an insurance division in my consulting company, so I'm very familiar with appeals and things like that. And I have to write a lot of them due to our clinical notes, due to us not backing up, sending in the Perio. So I feel strongly about it. If we can hit them with all the ammunition in the beginning, it's less fighting that our front office has to do on the back end, or even worse, the claim never gets paid. And it's either the office is eating it, the doctor's eating it, or we're reaching out to a patient. And it's usually, unfortunately, the office, because if you've told a patient that they're covered at 80%, even though we tell them that, if the insurance doesn't pay, they're responsible. When we're hundreds and hundreds of dollars off, that's a really hard fight. We're probably going to lose our patient. So now the dentist, the doctor's eating it, which isn't fun. They're small business owners. We never want to cause any more issues than, poor things already have. Okay, so it guides recare and maintenance. So it tailors how our follow-up intervals will be based on the risk, based on their staging and grading and their oh, I guess I said it, staging and grading, sorry. Improves referrals. So it better tells us when we need to refer to a periodontist. And then if we do have to send them to their physician for a backup because of diabetes or anything else, like if they're going back, they can easily say, I have stage 2, grade B, periodontal disease. And that's going to make more sense to the periodontist, and it's going to make more sense to the physician that's seeing them for other things. So this system promotes consistency. It improves communication. It helps explain risk to the patient in a way that's evidence-based. So we want to be evidence-based. It improves understanding, creates better motivation, clearer long-term goals. And it's not just a cleaning, but I want this to resonate. It's a chronic disease management at this point. So they have a chronic disease, and now we have to manage it. So we are chronic disease managers. Okay, so I'm going to play a video. You guys are going to make fun of me because I'm horrible with accents, but I'm going to say it's British. Um, um, little hard to understand, but I think you'll understand because they're talking about Perio and great pictures and follow alongs here. And then of course, when we're done playing the video, we're gonna recap it. So if you something it is pretty fast, so it is a little confusing. But just follow along and then we'll talk about it when it's over. Let me know if you guys can't hear this, but you should be able to hear it because we tested it.
Paula, I don't know if you can hear me. We can't hear the sound on the video. Can't hear the volume. And now we can't hear you. We need to reshare your sound.
Oh, I muted myself because I was taking a drink and I didn't realize it would affect my sound. Okay, let me start over. I don't know how far we got. Sorry about that.
Today we're going to explain the new periodontal classification system, which was released last year following the World Workshop in Periodontology in 2017. Previously, there were four main categories of periodontal disease according to the old 1999 classification system. Necrotizing diseases and periodontal diseases as a manifestation of systemic disease remain the same. However, aggressive and chronic periodontitis have been replaced with a single category called periodontitis. This new category has two key components, staging and grading. Staging represents the severity of the disease. Stages 1, 2, and 3 are synonymous with mild, moderate, and severe categories of the disease used previously. This was based on clinical attachment loss in millimeters. Stage 4 represents the most severe form of the disease, where other complexity factors may be present, such as vertical bony defects, excessive tooth mobility, and the need for complex rehabilitation due to tooth loss. The BSP recommends that the staging can now be done based on radiographic bone loss rather than attachment loss for clinical ease. Stage 1 represents less than 15% bone loss. Stage 2, bone loss limited to the coronal third of the root. Stage 3, bone loss reaching the mid-third of the root. And Stage 4, with bone loss reaching the apical third of the root. The second component is grading. This represents the rate of bone loss that has already taken place. Grade A is a slow rate, grade B is moderate, and grade C is a rapid rate. This can be calculated using a simple calculation where the percentage of bone loss is divided by the patient's age. To make it easy, you only need to remember the extremes of bone loss. So if the percentage bone loss is less than half the patient's age, it is grade A. If the percentage bone loss is greater than the patient's age, it is grade C. Everything else in between is grade B. To put this in the context of time, someone with grade A bone loss can expect to lose about 30% of bone by the time they're 80. Someone with grade B will lose up to 80% by the time they're 80, and someone with grade C is likely to lose their teeth in their 50s or 60s, or even sooner. In summary, the new system includes staging 1 to 4 based on severity and grading A to C based on the rate of bone loss. When making a diagnosis, we can also include information about how widespread the disease is. 30% of the teeth affected being the cutoff point between localized and generalized. In some cases, a molar incisor pattern may be found. The BSP recommends including additional secondary criteria as a part of the diagnosis, such as the stability of the disease and the presence of other risk factors such as smoking or uncontrolled diabetes. Let's look at an example to see how this system can be used in clinical practice. This is Charlie, who is 45 years old. A periapical radiograph shows bone loss extending to the mid-third of the root. This puts him in the stage 3 category. If we were to divide his bone loss by his age, we would get a ratio of greater than 1, which is classified as grade C. Charlie has a high bleeding score and pockets ranging from 5 to 7 millimeters, which means his disease is unstable. He also likes to smoke, so we can record this as a risk factor. Finally, most of his teeth are affected, so his disease is generalized. As a result, the diagnosis is composed of 2 key components, staging and grading, and 2 secondary components indicating stability and the presence of risk factors. There are a few additional points to note. The staging and grading is used based on the worst tooth in the patient's mouth. Secondly, we consider it to be best practice to use clinical attachment loss in conjunction with percentage bone loss wherever possible to make our diagnosis. Finally, don't forget to use your clinical judgment and common sense rather than getting lost in the specifications and technicalities when using this new classification system.
Okay. Well, hopefully, that was entertaining and good for you. And you got something out of that. But let's kind of recap, what he said here. So, first of all, this is always on the worst tooth in the mouth. So just remember that if we've got, one, well, we'll go through it, but basically it's always on the worst tooth in the mouth. Okay. So staging of periodontitis is the extent and the severity. So staging is based on the clinical attachment loss, radiographic bone loss, and tooth loss due to periodontitis. It reflects how severe the disease is and how complex treatment will be. Okay. So hopefully you guys can see this a little bit better than I. It's really tiny for me, but basically the clinical attachment loss is 1 to 2 milliliters. Bone loss is less than 15%. Probing depths are equal to or greater than 4 millimeters. And at this point, there's been no bone loss, or I'm sorry, no tooth loss due to periodontitis. So if they've lost a tooth, they cannot be stage 1. And this mostly consists of horizontal tooth loss. When we get to stage 2, clinical attachment loss is 3 to 4 milliliters. Bone loss is the 15 to 33%. Probing depths are equal to or greater than 5 millimeters. And again, no tooth loss due to periodontitis. And again, mostly horizontal bone loss on this stage. When we get to stage 3, this is severe with the potential for tooth loss. So the clinical attachment loss is greater than or equal to 5 millimeters. The bone loss is extended into the middle, the apical third of the tooth. Tooth loss less than, so 0 to 4 teeth, so less than 4 teeth. Or 4 or less, I should say. Probing depths equal to or greater than 6 millimeters, and vertical bone loss. Usually, or sometimes there could be furcation involvement, could be possible here. And then when we get to stage 4, it's everything in stage 3. Plus, we usually have bite dysfunction. So there's some bite dysfunction here, bite collapse, tooth mobility, tooth loss. It could have some of these, not all. Severe rigid defects, drifting, flaring. So there can be all kinds of things happening in that stage 4. And again, it's the worst tooth in the mouth. I don't know why it's not. advancing. Hang on. Okay, there we go. Okay, now we get to grading. And again, this, this was put out in 2017. And it's kind of now just taking hold. So just so you know, one of the things that it says at the top here is clinicians should initially assume grade B disease and seek specific evidence to shift to A or C. So as I go through this, you're going to kind of go to B. And then if you're not seeing the clinical evidence, you're like, no, obviously that would be A. Anything more than that's going to be a C, but it says kind of start with the B. So grading a periodontitis is the rate of progression. So grading predicts the rate of the disease progression, and it helps identify risk factors and informs long-term prognosis. So if we're about to do a procedure on a tooth, whether it be clear aligner therapy, a crown, a root canal, it's why they always want to see the apices of the tooth, why they want a picture of the tooth, because if there's poor prognosis, it's going to get denied. So this is really going to help, again, when we're submitting on insurance. So grade A is going to be slow progression. There's no bone loss or clinical attachment loss. There is bone loss, sorry. No bone loss or clinical attachment loss over 5 years. Heavy plaque, minimal destruction. So that's going to be the next, or non-smoker or non-diabetes. So they can only be in grade A if they don't have any of those things. Grade B is going to be moderate progression. So less than 2 millimeter bone loss or clinical attachment loss over 5 years. It's going to be destruction in line with the plaque level, and smokers that are less than 10 cigarettes a day, and A1C is less than 7%. So there's some underlying factors there that we're going to want to look at. And then grade C is going to be greater than, equal to or greater than 2 millimeter bone loss or clinical attachment loss over 5 years. Sorry, I'm talking too fast. The destruction exceeds expectations given biofilm. And the smoker, it's a smoker of greater than, they don't have to be a smoker. It just takes them into that grade, just so you guys know. Equal to or greater than 10 cigarettes a day, or if their A1Cs are greater than 7%. So all of this stuff would immediately, one of these things would immediately put them into the rapid rate loss. So, okay. I saw this in another webinar at some point, and I created my own. If you guys want to take a screenshot of it, you're welcome to it. This is something I'd be happy to share. Basically what it does is, grading helps define how fast, like I said, the disease is progressing and how much risk is involved. So we're looking at bone loss versus age. So in that video, he talked about this, but it was kind of quick and confusing. So I just kind of want to show you here with the chart I created is like, so we're just going to go, let's put our eyes on the age 40 just for fun. So age 40, if they're at age 40 with less 5% or less bone loss, they're grade A. So it's the light blue. But you can see that at age 40, if they have 10%, they automatically are in B, grade B. And then if you, oops, shoot, I touched my screen, sorry. If you go to, oh, gosh, I'm so sorry, guys. This thing is super touchy. Hang on. It's got a mind of its own. I have a Mac, and when I accidentally use my mouse right now, it's in double click mode. I don't know really how to get it off, and it makes things jump around really quickly. So I'm not going to touch it. If you look at 45, I think that's 45. I was trying to keep my eye in the right place. So if they have 45 bone loss at age 40, they're going into C. So hopefully you can see how this chart really helps me. I just, had this hanging up and laminated. Quite frankly, I have this and this and this, and then my next slide all laminated and ready to go. So I can educate. I don't spend a lot of time sharing the staging and grading with the patients or this one. This is actually for me so that because it's in clinic, I want it laminated so I can clean it really easy. But my next slide is what I do use for education. Now, all of these are grade B, but I think, it's the stage that patients are going to understand the most. They're not really going to understand the rate. They're going to understand the severity. So I don't feel like I really need to show them, I can't really even show them what grade A, B, or C looks like unless I had a patient of every age. So here, you want to use visual anchors. They say a picture is worth 1,000 words, and I think, gosh, like 65% of the population or something is a visual learner, maybe even more. So you really want to use a little bit of visual aid, but I usually am typically asking my patient if they're big picture, little picture, detail oriented, and then I'm kind of altering my education based on their learning patterns and who they are. And we'll get into verbiage here in just a minute as well. So what these stages actually look like are shown on here, and using these for education, I can't say enough about it. So you could find something like this on the internet. I got this off the internet. So just looking up staging and grading and finding something that hopefully you guys can see these different, the bone loss and how it gets much more severe. And patients can't always see that recession. Sometimes that gum level is up a little higher. So helping them know that that's what's under there is always good. Okay, so now that we've talked about health, gingivitis, periodontitis, we've described the different stages of periodontitis, and I know that was pretty quick. At the end, if we have time for Q&A, I'm happy to answer some questions. I don't think it's a one and done learn. If you guys saw that first thing I popped up, I mean, I probably had to watch that Charlie video 4 or 5 times. I had to start utilizing in the practice. I had to hang my charts. It's not like I took a crash course and like was an expert in staging and grading the next day. So don't get frustrated with me and don't get frustrated with yourself. If you leave tonight and you're like, wait a minute, because that's pretty normal. It's complicated, it's deep, and you need some cheat sheets, typically to get you through it until you've done it enough that it becomes like the mild, moderate, severe for you. And I don't know if we'll ever get there because we don't get to generalize like that anymore. So it's much more complicated. And again, it's very specific based on the staging and the grading and the tooth loss and the bone loss and the, all of that stuff. So there's a lot. Okay, so let's talk about patient-centered verbiage for these periodontal conversations, because this is where real world comes in, and this is where you've got to sit chairside and tell me, your patient, that I have periodontal disease. So we use co-discovery. We want to involve the patient in their own diagnosis. So instead of telling them what's wrong, I'm typically showing them. I'm using mirrors, I'm using photos, I'm using Perio chart, I'm using radiographs. I'm using that display of pictures I just showed you. And I might say something like, let's take a look together. I'm noticing some signs I want you to see too. And that's probably when I'm using the mirror. I want to create buy-in, not resistance. So if I'm talking at them, I'm not going to get as much buy-in, but when I'm showing them the probe sinking in, I'm showing them the bleeding, I'm showing their radiograph where their bone level should be and where it's at. When I'm discussing, even, teeth lost due to periodontal disease, if they even know they lost it due to that, all those different things coupled with, especially if they have underlying health issues, this is all a big conversation. Then we move into trust building communication. So it's very important to describe inflammation and bleeding in a way that patients can relate to it. I'm not using jargon. I'm using clear comparison. I even might say something like, bleeding gums are like a warning light on your dashboard. So it's your body's way of saying, hey, something's wrong. Bleeding is, we sometimes we'll say, if your eye bled, would you let it go? I mean, we get a little harsh sometimes, or say things like that, or, we have different analogies, but I really like, it's like a warning light on your dashboard. So it's telling you something's wrong. There's something wrong in there. We don't know how severe unless we take the car in and do a diagnostic test. But what we know is when you see that at home, that's your body telling you, hey, this isn't good, right? And now you're coming in for that assessment, for that diagnosis, and that's what I'm here for. When we're talking about infection, avoid shame or blame, which I know most of us do. As a matter of fact, I feel like we probably even minimize it too much. So I'm talking, I'll say to them, gum infection is really common. Matter of fact, half of Americans have periodontal disease over the age of 30. Luckily yours is gingivitis, if I'm talking about, gingivitis. And the good news is at this stage, it's reversible with proper care. And this will give the patient hope and motivation. And it also lets them know that it is reversible with proper care. So when I'm enrolling periodontitis, it's going to look a little bit different, but I'm still going to say, the good news is we caught it early enough that we can treat it in our office. You don't have to have surgery at this time. If we keep you on that maintenance program, I feel confident that we can keep this at bay for a really long time with what we do together. So there's always that good news conversation before the bad news. So no matter what stage I catch it at, even if they lose a tooth to periodontitis, I don't say at least it's only one. I wouldn't say that to a patient, but what I'm going to say is I'm happy we caught it today. We are going to unfortunately lose a tooth, but I feel very confident that we can keep the rest. So I'm putting that positive spin on it, even though there's also something negative in it. So I'm going to say it looks like it's been a while. So if I'm talking about gingivitis, it's going to be a little lighter. I'll say it looks like it's been a while. It looks like you've missed 2 professional cleanings, 4 professional cleanings at minimum, right? If they've missed 2 years. So it's been a while since we've cleaned around the gum lines. So we have some catching up to do today. Would you agree? And I'm trying to get their buy-in on that. So our goal today is to reset things and keep things from progressing into something more serious. So hopefully you guys I can kind of wrap that up again one more time there. So remember, we're not selling. When I'm coaching, I call it enrollment, or sometimes I'll alternate with selling, but selling has a bad name because we think of selling as we're talking a patient into something or somebody into something they don't need, because we've all had that experience in some way or another. But we're selling, and that's why I changed it to enrolling, because we're selling something that patients need. And unfortunately, we know better than them what they need. And we know the repercussions of not moving forward and what it's going to lead to better than them. So sometimes we do have to be a little tricky, a little, find the right words, and never salesy. But what I mean by selling is finding ways to sort of put that positive spin on it so they can see how important it is that we move forward. We're partnering with our patients and we're helping them keep their teeth for a lifetime. And we want to empower them. So with all of that, again, just to wrap that up, and I think my next slide is quite a bit of conversation too, so I might have some repetitive things here. To wrap that up, it's basically I'm talking about the good news first. If they want the bad news first, I can give it to them. It's going to take some time of money and some time, and it's going to take investment of your time and money. And unfortunately, we're here, but the good news is we can go here. Or if I give them the good news first, I'm talking about how far it's penetrated, and there is something worse if left untreated. So I'm here to help them get to that so it doesn't progress into something more serious. So we're co-discovery, building trust, again, describing the infection in a way that they can understand, and then using those enrollment phrases so that they can realize how bad they actually need this. Okay, so again, we're here to help them understand the value before cost, but ultimately we do have to get into that financial conversation. Now, sometimes it's not us, sometimes it is, but this is really good for your whole team to be on the same page, because we do, financial conversations lead to yes to treatment plans. If we have some scripting, and it doesn't have to be the exact same words from everybody, but we're on the same page when we do this. So we're going to do our best to maximize your insurance, but your long-term priority is, or my long-term priority is your health. So I don't want to get too much into insurance, but what I'm always asking my patients is what they value most about their oral health. And if it's to save their teeth for a lifetime, all my conversations after that are going to be to help them save their teeth for a lifetime. So again, we'll do our best to maximize your insurance, but your long-term health and oral health is our priority, and we're here to help you keep your teeth for a lifetime. So addressing the cost concerns is, again, seems a little tacky. It has to be in the right setting. The conversation has to flow. So again, creating systems and verbiage so that you're comfortable practicing and then putting it in your own words so it comes out right. If you try to repeat what I say, what someone else says, you might stumble, which is fine as well. But think of this as an investment and in avoiding surgery or tooth loss later. So this is an investment that helps them avoid surgery or tooth loss later, so that there's always something worse, right? We want to empower them to be in control. So I tell them, you're in control. My role is to support you with the best care option. So I'm here to diagnose, tell you the treatment. Ultimately, it's your decision. And I do believe that confidence and clarity is what equals case acceptance. So, which is ultimately what we want. We want that for the practice. We want that for the patient. We want that for ourselves, because we're the ones that have to see them next time if they don't move forward. So there's a lot of things that go into that, and we want to make sure that, we're moving toward that. So some of the things I'll say is, today's visit shows signs of active infection. To get ahead, this is that we recommend scaling and root planing. We'll work with your insurance to cover as much as possible, and have, Josie or whoever up front break down the estimated out of pocket for you. I think that they need to know that you're sensitive to those kind of things, and letting them know that it's a big decision. And unfortunately, avoiding is only going to cost more time, more money, more aggressive treatment later. I wish I could ask you guys your feedback. Like, does that mean I'm so used to coaching and saying, does that make sense? Did I say enough? Because I don't want to stop, if it's not jiving with you. But I think putting them in the driver's seat. The other thing that I like to make sure that I do is I want to make sure that I like to incorporate really strongly. I know we all look at their medical history, but I think that they know that you're looking at them as a whole body. The more, again, the staging, grading, these conversations will help create value and trust. So whenever I'm getting a medical history, not only am I looking at it, I'm letting the patient know that I looked at it. I thank them for filling out, that long documentation, but I want them to know that we here at the practice, we all take this into consideration when we're creating any kind of treatment plan or even their next visit moving forward. And I try not to say, are you allergic to anything? Like, obviously, if they wrote it down, I want to say, I see you're allergic. Is there anything else? Tell me about the allergy. I see you have cardiovascular disease. When was that first diagnosed? Whatever that is, what I don't want to say is, do you have any heart issues, when they've clearly wrote it on there? So again, thanking them and then utilizing that. And then I'm going to pass that in my handoff to Doc, so Doc also doesn't make that gravely mistake of saying something after a patient took 20 minutes to fill that stuff out. I also do the same thing with the radiographs. I want to make sure that they know I looked at them, doctor looked at them. We know that, it can, sometimes be, not the funnest experience. However, we're taking this all into consideration when we are creating these treatment plans or future visits for them. Even if it's just a 6-month recare, we want to make sure that it's because we have diagnosed that they're healthy and this is what's right for them. Okay. So we must tie in the diagnosis with the right code. If you don't know your codes, I, again, strongly recommend, we don't have a ton. You don't have to know implants and crowns and all of those, but just our codes. I typically change them in the back, if they've gone from on my schedule to a prophy to a 4346, I want to make sure that I'm changing that. I don't want, the mistake of that being charged out wrong, things like that. So a couple of things I'm going to say about, not going to get into too much. I think I actually do get into coding. I'm going to talk about it in a minute. I think I actually get into it a little bit. So again, just a reminder, less than 10% bleeding is health. You're going to have those 10 to 30 that you're going to have to make a clinical decision on how you want to move forward with that. I usually, when I diagnose a prophy of someone who is not less than 10% and they're not gingivitis, what I'm typically doing is putting them on a less frequency. So instead of 6 months, it might be 3 or 4 months because obviously there's something going on in there. We're teetering on the gingivitis therapy, being diagnosed as gingivitis, and I don't want to leave them out there in the world 6 months with the chance that they're going to tip that scale and go into gingivitis. So what I'll do with those patients is get them on a tighter frequency until I see complete health, less than 10%. And then I'm fine taking them back to a 6-month recare. On the gingivitis therapy, again, 2 appointments. Everybody knows how to treat perio, and then that perio maintenance phase. So just making sure that we've got the right coding with the right treatment. Okay, my next, I won't spend a ton of time on this, but I think this is super important. And in all the practices I go in, I would say this is one of the biggest challenges or hiccups, and that is notes, clinical notes. So if you haven't heard of SOAP notes, we're going to talk about them today. So the S stands for subjective. So subjective is what the patient is reporting or feels. So we want to make sure that we have a clear and defensible structure, not only in case insurance comes after us, the board comes after us, or even our colleague has to take care of this patient on a day we're not there. Our clinical notes can also save us a ton of time if we've got templates. So again, this subjective is what the patient reports or feels. Objective is the periodontal, it is what the clinician observes or measures during the exam. So the perio charting, the radiographs, the anesthesia given. Now, it's going to feel like the anesthesia given goes under plan because plan is what you're doing today, but really it falls under here because it's measurable and it's part of the clinical setup. So it's not the procedure itself, but let me tell you, if you put it under the plan, I'm fine with it because you've got it all in there. But this really technically is the clinical observes or measures during the exam. Then we have the assessment phase. So this is the diagnosis or the clinical interpretation based on subjective and objective findings. So based on what the patient said, what we found, now we're creating our assessment. So generalized stage 3, grade B, periodontitis, and we're putting that diagnosis right there. And last but not least is the plan. So this is what we did today, the treatment provided and the next steps. So the SRP, the reeval, the home care, the consent forms, all of that. Again, the order matters less than getting it all in there. So don't freak out. It's one more thing to learn. We already got the staging and grading. If we get that down, we're doing great. Really, this is about having thorough notes, making sure you're covering yourself, your practice, your dentist, and the patient so that we know what we did today, what we need to do, especially again, if more than one hygienist. I don't know about you guys, but I see so many patients, I can't remember every little thing. So I have to write it down. It's just facts. Okay. Metrics that matter. Again, we want to make sure that, this is a sensitive subject. A lot of practices aren't here, but these are statistics that basically should be there. So diagnosis, so basically, diagnosis, our active diagnosis with gingivitis or periodontitis should be 35 to 50% of our practice. Perio should be 30 to 35. I put 30 to 35. That should be 35 to 50, that first metric, sorry. Then 30 to 35. 43, 46, which is gingivitis therapy versus 110. Percentage of patients with gingivitis appropriately receiving gingivitis therapy should be 50 to 15% of all of those other patients that we're not doing perio on. So I know that's a little confusing, but there's calculations that help look at the active patients in hygiene, how much is diagnosed with perio, how much is diagnosed with gingivitis, how much is healthy. Of the ones we diagnose with perio, we want about a 75 to 90% acceptance rate. So that means we're great at enrollment. We're educating the patients where they can understand, they're trusting us, they're valuing what we're saying. So of that 30 to 35%, when we diagnose it, we should have a 75 to 90% enrollment rate. Of the patients that we enroll, we should have a retention rate of about 85 to 95% that stay in a 4910. So there's those localized one quad that we might take back to a prophy. So there's circumstances where they aren't a 4910 forever and ever. So that's what that statistic is looking at, is those patients that had very localized areas that we now take back to a prophy. Of the patients that we diagnosed with gingivitis, we diagnosed with perio, we should really be doing a 6-week reeval at about a 90 to 100%. This is a difficult one for offices because it really should be a 30-minute appointment. They have a hard time fitting it in. It's not a real money generator. There's ways around that. So that's a bigger, longer conversation. But I really do like that 6-week reeval. I mean, think about it. Patient, you have a disease. It's much like diabetes. You'll never get rid of it. You can only maintenance it. And I just got done treating you. I'll see you in 3 months. Probably not the best setup, but I do know that there are time constraints. Your hygiene department's full. You're not 100% in charge. It's how do we fit that 30-minute appointment in? If we do an hour, it makes no money. There's all kinds of things that go into that 6-week reeval. So I wouldn't recommend just going back tomorrow and doing it if you're not set up for success, because it can be really deflating and complicated for everybody, including your front office team. They might hate you. And then adjunctive therapy acceptance, 25 to 40% on that. That's rest and laser and irrigation, not fluoride. So it brings me to my next slide, which is basically saying, what does this even mean? 30% of your active hygiene patients should be diagnosed with periodontal disease. It aligns with the national disease prevalence of the 50% of over age 30. A low percentage may signal underdiagnosis or miscare opportunities. I'm sensitive to that because I don't know you all and I can't see your faces, but true statement. If it's lower than that, we might be underdiagnosing. It drives hygiene production, coding accuracy, overall patient health outcomes. It's a benchmark. It's a national benchmark. So I didn't make it up. It's national. So it is that benchmark that we should be using. And it can be higher if you're actively diagnosing. So I've been in practices where the reason they're 30% is because somebody else diagnosed and they've got half their patient base in 4910s, but we're not actively diagnosing. So there's all kinds of things that go in to this percentage. But I'll just kind of leave you with that. And then adjunctive services, we're getting there. Adjunctive services, use them ethically, document them thoroughly, and they support clinical outcomes and can boost hygiene production. So I'm using them because they support outcomes, but it also, the bonus, the cherry on top is it does boost, the hygiene department or production. So subgingival irrigation is used with inflammation and bleeding and deep pockets. So sometimes with gingivitis therapy, with perio therapy, and even at those perio maintenances and reevals. So again, you have to set up an actual program, system protocol, a perio program, an SOP for your practice. So if what, then what happens here, that should all be really defined. And then obviously make sure you chart if you used it. Laser therapy is an excellent tool for reducing bacterial load. Again, I've been using, honestly, my whole hygiene career, but my very first year. So I've been using lasers for 27 years. I was lucky enough that the second practice I worked at had them and they were like, here you go. And I was like, am I legally even allowed to use this? So I had to take some courses and figure out what the heck I was doing because I had it like turned up. Sometimes I did things I, didn't even know what I wasn't doing right. And so lesson learned. That was only a very short period. I learned quickly what not to do. And my last, 26 and a half years have been successful. So this is going to promote healing. This isn't a laser course, so I'm not going to get into that. Some people will use vitamin E oil, especially after laser. Oricare is awesome. Fighting against VSCs and bacteria. There's quite a few mouth rinses out there that are chlorhexidine has some contraindications. If you don't know about it, you should probably look it up. I'm not telling you not to use it. You work for a doctor, you're a clinician. There are just some contraindications, and some people are getting out of using that. And then, of course, I've talked about ethical billing a ton already. We're at our last couple of slides, promise. Okay, key takeaways. So what I hopefully, your key takeaways are gingivitis and periodontitis must be accurately diagnosed using staging, grading, and classifications, and diagnosed with clarity. Hopefully you got some verbiage in co-discovery. Co-discovery builds trust and drives case acceptance. And so communicate with empathy, put the patient in the driver's seat so you co-diagnose so you can build trust and they value what you're saying. Coding accuracy, that's going to impact patient's outcome and hygiene department. Code with integrity. Again, I want to catch my patients at the earliest signs of disease. It's less invasive. It's less expensive. It teaches them quickly that they're going down the wrong path. They're going to keep doing the same oral home care if we don't let them know where they're at. Adjunctive therapies, we kind of brushed over that, but that adds value. So hopefully you're using some. Obviously, billing ethically is always the right thing. And then tracking metrics helps guide strategic growth and care consistency. It's honestly, we use metrics for everything. We use metrics to cook. We use metrics in health, exercising. You can't really know if what you're doing is working if we're not using some kind of measurements. So I love KPIs, which are key practice indicators. You don't have to do a bunch, but just where do we stand? How do we look? So we walk through diagnostic integrity, powerful communication techniques, accurate and ethical coding. So I say just pick one thing when you go back. It's a lot, but change starts with one intentional shift. So just pick one thing that'll improve the way you care for your patients or communicate with them. And maybe it's just using the word inflammation instead of a little bleeding. I sometimes I call them swear jars in practices. And every time I hear little or kind of, I make them put money in the jar and see what it looks like, when I come back. So those minimizing words minimizes what's going on in there. You never hear from a physician, you have a little something. It's always you have a break, you have this, you have that. So just kind of remember we are healthcare providers that focus on the mouth. So treat with confidence, diagnose with clarity, deliver with purpose. That's my message to you today. And if you want to check us out, if you have questions, you can find me pretty easily. I just popped up some reviews just because I do want to talk about if I don't know what your guys' timing is there because I can't see anyone. And then we do have a podcast. I'm not promoting me. I'm really just promoting you be able to find me if you have additional questions after this. My passion is helping hygienists. I love helping dentists. So if there's anything that I can provide for you that will help you when you go into work, tomorrow, next week, I'm happy to share. So that concludes today's stuff I have. You all there?
Thank you, Paula,
Oh,
for presenting to our study club. We do have a few minutes for questions if anyone has any.
yeah. And I felt like that was a speed round, but I had so much information. I wanted to make sure that I could tie it all together. So hopefully it wasn't too crazy for you all.